Sarang, is everything okay? Can we start?
Yes, sir. Everything's okay, sir.
Okay, fine. Hurry. Still a few people coming still. Right, okay. So let's start. So today is the fourth session, and we are going to discuss the abdominal examination. So up to now, we have talked about, on the very first day, we talked about effective case presentation in medicine and how to effectively take a history and present your findings at an exam as well as in your routine day-to-day ward classes. And there we discussed about diagnostic cases and management cases and how to tackle both of these types of cases. Then we talked about the cardiovascular system, the technique of examination, and then how to interpret physical signs in the cardiovascular system. Okay. And then we moved on yesterday to talk about the respiratory system. Again, talking about physical signs and then interpretation. And finally, we ended off with a summary table of all the respiratory disorders. And I asked you to do some homework. I saw that somebody had posted something, which is good. So make sure that you read that and understand some of the other physical signs of a cavity. Right? We discussed yesterday. Hari, now I told you that the respiratory system is slightly challenging because the physical signs can be variable and it's difficult sometimes to put everything together. So you need a lot of practice when it comes to the respiratory system. Now, the abdominal examination, if you were to say from all the systems, the abdominal examination is probably the easiest. Okay, it is the easiest, but you have to make sure that your techniques are correct. So the first half of this discussion, we will focus on the correct examination techniques for the abdominal examination, and then interpretation of physical signs is rather easy, and when you will also realize that it's mostly memorizing some lists at the end. Okay, but the interpretation is relatively easy. If you find something, it is easier to interpret it rather than some of the other systems where you have to put a lot of thought into analysis of signs. Okay, Hari. So the abdominal examination, so the first part of this presentation, we are going to talk about the technique. Now, as all the systems we have discussed, the abdominal examination is similar, okay, where you have a general examination and then the abdomen proper. The abdomen proper, you have the inspection, palpation, percussion, and auscultation, the usual components you would have in the examination. Okay. Now, obviously, like in the other systems, you introduce yourself to the patient, explain what you are doing. Now, in the general examination, there are several physical signs that are important. Okay. Jaundice is an obviously important sign to pick up in the general examination of relevant to the abdomen. Okay. And jaundice can be various things, and the differential diagnosis is rather broad. So we'll come to that at the end. Okay. Now, with the jaundice also, you have to look for other peripheral stigmata of chronic liver cell disease, which is very important. They are commonly seen in patients, so you need to look out for them. Okay. So leukonychia, this is predominantly due to low albumin. Okay. Because of the loss of the synthetic function of the liver. On the right hand side is palmar erythema, which is again a peripheral stigmata of liver cell disease, actually due to the vasodilation that occurs in chronic liver cell disease. On the left hand side, you will see a diputran contracture, which is actually associated with chronic alcohol use. There are other causes of diputran contractures, obviously, but relevant to the abdomen, the most important cause is long-term use of alcohol. This is how to examine for flapping tremors or astrexis. We saw this yesterday in the respiratory system as well. And this is the same principle you use to examine astrexis or flapping tremors in the abdominal examination. So remember that you will get this sort of movement at the metacarpophalangeal joints. It doesn't go at the wrist like that. It goes at the metacarp. There is a slight flexion of the metacarpophalangeal joints there. Okay? And that is a flapping tremor, and this is seen in patients with liver failure. Or in other words, you call this decompensated cirrhosis. Okay. Gynecomastia, again, feature of chronic liver cell disease due to estrogen, elevation of estrogen levels in males. And this is a spider nevi. And spider nevi are usually seen in the distribution of the superior vena cava. Okay, so it's basically above the nipples that you're going to see this, and that's important to note. Okay, and when you press on this spider nevus, you will have emptying, and then when you take your finger off, it will fill back up again. Ankle edema, again due to the hypoalbuminemia, and edema due to liver failure, liver disease. So these are some things that you need to make sure that you note. Additionally, obviously, in the abdomen, you also have to examine for lymphadenopathy, which is again important, especially the supraclavicular nodes on the left side can be enlarged in abdominal pathology. Okay, so make sure that you examine for that. Axillary nodes also probably are important to examine. Okay, and when you go to your wards, they will teach you the clinical exact techniques of how to look for those lymph nodes. Right, so general examination, look for jaundice, look for features of peripheral stigmata of liver disease, ankle edema, lymphadenopathy. These are some of the important things that you look for. There are others, but these are the most important things. Pallor is obviously another important feature that you look out for. Pallor or plethora can also be relevant in some specific cases in the general examination. Hurry. Now, then when we go to the abdomen proper, you have again the 4 components: inspection, palpation, percussion, and auscultation, the 4 components of the abdomen. So starting off with inspection, adequate exposure needs to be there. Ideally, you should expose the groins as well, but in the walls, sometimes it is difficult if you don't have adequate privacy to do that. And inspection is started from commenced from the foot end of the bed. Again, go down on your knees, go down to the level of the bed and look at the abdomen. And this is important. This is something that we actively look out for when you come for your exams and also in the wards. Okay, so go down to the level of the bed and observe the abdomen for distension, symmetry, and any obvious masses. Now remember, one of the key things that you will see in this position is in polycystic kidney disease, you will see obvious flank fullness on the sides. And this is something that you can catch even with careful inspection. So foot end of the bed, look for abdominal distension, look for obvious masses, symmetry, and then look at the flanks, because flank fullness on both sides can indicate polycystic kidneys. And then you move closer to the abdomen, looking for surgical scars, umbilical deformities, deposits in the umbilicus, very rarely, that's called Sister Joseph's nodule, and also dilated veins. And also you can inspect the skin of the abdomen for any obvious rashes. Right. This is just a revision. Now it's very important, again, when you come to the wards, we will show you how to examine the abdomen properly, right? And basically, you start off with a superficial palpation, going from quadrant to quadrant to quadrant, okay? And basically, you're looking for any tender areas in these quadrants. Sometimes if it's a massive mass, you will feel it, but generally the superficial palpation is intended to look for tender points. Okay, and move from quadrant to quadrant. Very, very importantly, so these techniques are very important. Look at the patient's face when you're doing the palpation, right? And that will be obvious if the patient makes a face or winces, that is an area of tenderness. Now, look at the way that I am examining the abdomen in these 2 pictures. So you can see that I have come down, okay? I am not examining it from the top. I have come down as much as possible to the level of the bed. Now, the classical textbooks on examination technique will tell you to kneel on the floor, but that's not really needed as long as you bend down and go down to the level of the bed. Make sure that your forearm, these are important, so write these down, make sure that your forearm is parallel to the bed, okay, parallel to the bed, and the tips of your fingers are touching the abdomen. But mehema neveyi, you should have the hand should be in very close, the palm should be in very close proximity to the abdomen, but the palpation is done by just your fingers. So it's something like this. The palpation part is by your fingertips, and the palm is very close to the abdomen. Okay, very close to the abdomen. And your forearm is obviously parallel to the bed. Parallel to the bed. So that's your palpation technique. Always look at the patient's face. Okay, again, I have demonstrated this. I'm bending down, going to the level of the patient, and I'm using my fingertips, as in this picture, to palpate the abdomen. Okay, and you can see that I'm trying to keep my forearm as parallel as I can to the bed, and my fingertips are slightly curved and palpating the abdomen. Right. So once you finish the quadrants, so remember the quadrants. You look at the quadrants: the iliac fossae, epigastrium, hypogastrium, right hypochondrium. All these quadrants you will examine. Okay, and then once you finish that, we go on to a deep palpation. Now, in medicine, the deep palpation is targeted for organ assessment. So basically, deep palpation is divided into liver, spleen, kidneys as the main masses. In surgery, however, you might get other masses from other organs or other structures in the abdomen. In medicine, we specifically identify or we need to detect liver, spleen, and kidneys. But basically in medicine we are focusing more on the liver, spleen, and kidneys. Okay, liver, spleen, and kidneys. And deep palpation for the liver, okay, is done like this. This was original video. It doesn't play anymore. This is probably because it's, I don't know, the links are probably not working. But when you come to the walls, we will show you how to do this properly. And already we have done this during your introductory appointments, okay? And I think I might have taught you that in your introductory appointments as well, that your fingers should go in during expiration, hold it in for a full cycle of breathing and then come out, okay? That is the proper way of examination. Okay. You can use your fingertips to feel the liver as well, or you can use this border or this border. No problem. Both are accepted. Okay, both are accepted. So start in the right iliac fossa and go up. When you feel the liver, percuss the lower border and the upper border of the liver. Then you go for the spleen examination. So spleen examination, start again in the right iliac fossa and go diagonally upwards towards the left costal margin. Okay. And again, use that technique. So make sure you write that down, practice that. Your hand, the pressure that you exert should be coordinated with the person's breathing. Okay. So when the patient is in expiration, you push your finger in, and then for a full breathing cycle, you hold it in so that any enlarged mass will come and hit your fingers as it goes down and then up. Okay. And then take your hand off. So expiration, push it in, keep holding it, wait for inspiration to occur, and any mass can come and hit your fingers and go up, and then take it up and gradually advance towards the costal margin. So in the case of the liver, you're going up to the right costal margin. In the case of the spleen, you're going up to the left costal margin. Okay. Right. So that is the spleen. And if you don't feel the spleen in the supine position, you always turn the patient to the left lateral position. Now look at the position that this patient is in. You can see that the patient is well rolled onto the left lateral position, okay? And the top leg is bent towards the patient, okay? The top leg, there is a left leg, is bent towards the patient, all right? And then you can see one of my hands, so my left hand is pushing from behind, giving pressure from the back. So it's pushing from behind, and my other hand is feeling for the spleen. So you will feel the spleen because you're giving pressure on the chest wall with your left hand and then you're feeling with your right hand. Okay, so that's the technique of feeling the spleen. Okay, and if you feel the spleen, again confirm it with percussion as well, like I have demonstrated in the picture onto your right side. So that's the liver and the spleen. So important, again I emphasize that you have to coordinate your palpation technique with the patient's breathing movements and breathing cycle. This is examination for palatable masses. The first thing is you do bimanual palpation in this fashion. Okay, both hands bimanually palpate karanawa. And if you feel a mass in bimanual palpation, you will ballot it. Ballot kiyanne with your lower hand, okay, you push the mass up. So if it's a ballotable mass, for example, like the kidney, it will come and hit your top hand. It will come and hit your top hand. Okay. Now, we talked about inspection. We talked about palpation. So palpation, two components. You have your superficial palpation for any tender points and then your deep palpation for organomegaly, that is specifically the liver, spleen and kidneys. Then we move on to percussion. Percussion, what you're doing is first you're looking for, basically the idea of percussing is you're looking for free fluid in the abdomen. Now remember, you have already done some percussion up to this point. You have already percussed for the liver and the spleen. If you find the masses, you would already do that percussion. So this section of the examination is specifically focusing on your percussion for free fluid in the abdomen. So as you know, free fluid initially accumulates in the paracolic gutters of the abdomen, that is on either flanks. So first you are looking for flank dullness. So you start percussing at the midline and going to the side laterally. Start there, look at the mouse pointer and then go to the sides. Okay, so that's basically how you're percussing. And also remember that abdominal percussion should be soft percussion. So write this down if you forget. It should be soft percussion. Right? It should be soft percussion. And you should be able to hear the sound. So you bring your ear close to the abdomen and use a very soft percussion. This is different from the respiratory system examination percussion, where you use a harder percussion. And ideally, your percussion should be heard by somebody standing at the foot end of the bed. That is respiratory system, hard percussion. In the abdomen, you're using a softer percussion note. Right. So if you find flank dullness, okay, you can also, what you do is you look for shifting dullness, turn the patient onto a side, wait for a few seconds, and then repercuss the dull area. If there is fluid, it will move out and that area will be now resonant. The area will be resonant. That is called shifting dullness. Now, once there is a little bit more fluid accumulating in your abdomen, fluid will begin to accumulate in the shape of a horseshoe shaped dullness. So you can also check for that. Remember, you percuss starting from, look at the mouse point again, start from there in the epigastrium, go down and you get dullness there. Start there, go down, you get dullness here. Start there, go down, you will get dullness there. It will be a horseshoe shaped type of dullness that you will get. Obviously, if the abdomen is grossly distended, you will get a fluid thrill, and the way you elicit is shown in the picture. You ask the patient to keep the hand in the middle of the abdomen and knock from one side, and you will find the pressure wave being transmitted onto your other hand. That is the way you look for. That is gross ascites, a large amount of fluid, and this is called the fluid thrill. So these are three levels of fluid accumulation. If you would understand that, flank dullness, okay, and shifting dullness would be fluid in the paracolic gutters. Then moving on, you are going on to percussion horseshoe shaped dullness, and then the fluid thrill as well as the last thing. Okay. auscultation is not a very important part of the examination, I have to say. Auscultation basically we are looking for bubble sounds, hepatic bruise, that's over the liver, and a renal bruise. Okay, renal bruise surface marked. This is the xiphoid process, umbilicus. A midpoint, you take the midpoint there, slightly lateral. So renal bruise, where you would hear the renal bruise, xiphoid process, umbilicus, and in that line, slightly lateral from that line. Okay, to the side, about 2 to 3 centimeters lateral from that line. That would be the renal bruit. Renal bruit. Okay, so that is basically your abdominal examination. Today's class is much shorter than the previous one because the abdomen, I told you right at the start, it is very easy here. So abdomen, make sure that your technique, I will summarize some of the key points that I have discussed so far. So in the abdominal examination, your technique starts off with a general examination, looking for jaundice, features of peripheral stigmata of liver disease, ankle edema, and so on. Lymphadenopathy is also important. There are some other signs which you will see as you go on. Then inspect the abdominal examination proper. You have inspection, palpation, percussion, auscultation. The key thing in your palpation technique is make sure that you go down to the level of the patient. Use your forearm. The forearm should be parallel to the bed. Tips of the fingers for palpating, but the hand should be in close proximity to the abdomen. So it shouldn't be like this. Should be more like that. More like this. Okay. Mehemma nevei, more like that. And just the tips. Okay. And then going on to deep palpation, we are looking for organomegaly, that is liver, spleen, and kidneys. Make sure that you use the breathing and coordinate your palpation with the breathing to palpate these organs. Press in during expiration, hold it for an inspiratory cycle, inspiration, and then take it out. Okay. Percussion, yeah, I'll show that again. Somebody had wanted me to show that again. So percussion, initially you look for flank dullness, that is fluid in the paracolic gutters, and then you would also look for shifting dullness. So if it's fluid, it will move away. So you hold the patient to that side and let the fluid drain out to the other side and then percuss again. So that area that was dull initially would now be resonant. So that's called shifting dullness. A little bit more free fluid in the abdomen will accumulate like a horseshoe. So how do you percuss? You start from the top at the xiphoid process, go down, and you will get dullness there. Start there, go there, and you will get dullness there. Start there, go down there, you will get dullness here. So that is horseshoe-shaped dullness. Horseshoe-shaped dullness. When there is more fluid in the abdomen, you will get a fluid thrill, and I have shown you how to demonstrate that. Auscultation is not very important. Right. Then Lamai, once you do your abdominal examination, there are two things to do when you're interpreting physical. So this is the second half of the discussion. When you do the abdominal examination, now you have to interpret the signs that you find. So basically, first thing is you identify any organomegaly, which is the most important thing to do. Okay. Rarely you might just get something just with ascites if you can't find any cases for you, that is for your exam. But generally you're interested more in organs, palpable organomegaly, right? And to identify the organ, and then you generate a differential diagnosis. Now this is where I told you, you have to memorize certain lists. So if it's a liver, you have to know all the causes of enlarged liver. Spleen, you need to know all the causes of enlarged spleen. Okay? And that is, you can generate the differential diagnosis. And another word about that, your general examination findings are going to help you to generate this differential diagnosis, as we will see in a little while. So how do you identify your organs? Spleen, liver, and kidney. So what are the physical signs of a liver? What are the physical signs of a spleen? What are the physical signs of a kidney? Liver is easy. Number one, the first physical sign is it is in the right hypochondrium. It is a mass in the right hypochondrium, right? Hypochondria. Okay. Then you cannot get above the mass. You can't put your hand above the mass. The mass doesn't have an upper board. You can't feel the upper board, obviously, because it is the liver. So right hypochondrium. So if somebody asks you, this is a very famous question at any time, even in your exam, when you find the mass, there is a hepatomegaly. Then they ask you, why do you think this is a liver? Why do you say this is a liver? So for that, your answer should be, it is in the right hypochondrium. You cannot get above the mass. It moves downward. Obviously, you can imagine the liver moves downward with breathing. Okay, moves downward with breathing. And you can also say that the percussion note is continuous with the hepatic dullness. Okay, percussion note is continuous with the hepatic dullness. So right hypochondrial mass cannot feel the upper border, moves downward with breathing, and then percussion note is continuous with the liver dullness into the chest. So these are the physical signs of a liver. Okay, මේක අනිවාර්යෙන් අර පන්සිල් පදේ වගේ ඕක මතක තියාගන්න ඕනේ. You need to know this, remember this. Okay, you need to remember this. Spleen. What are the physical signs of a spleen? So again, it's very easy. Spleen, location, left hypochondrium. You cannot get above the mass. Again, spleen, you can't feel the upper border because it continues under the chest wall. Okay, so left hypochondrium, you cannot feel the upper border. And you know that it moves diagonally. Moves diagonally with breathing. And you know that it enlarges towards the right iliac fossa. So spleen moves diagonally with breathing and enlarges towards the right iliac fossa. Enlarges towards the right iliac fossa. Okay. And sometimes you can feel a notch in the anterior border of the spleen. Okay. Sometimes you can feel a notch in the anterior border of the spleen. This anterior margin, you can feel a notch. So again, I tell you, left hypochondrium moving diagonally with respiration, okay, enlarging towards the right iliac fossa. You might feel a notch in the anterior border of the spleen. Percussion note, again, it's like the liver. It is continuous with the splenic dullness into the left chest. Okay, so it is continuous with the splenic dullness. Renal mass. What are the physical signs of a renal mass or a kidney? Location in the flanks. So that's why I told you, even on inspection, if you look carefully, you will be able to see this flank fullness. So it is in the flank or the posterior, the loin region. So the enlargement is in the loin, right? The movement with respiration is very minimal. It doesn't move a lot. It does move, but it doesn't move a lot. So there is some movement, but a minimal movement with breathing. It is bimanually palpable. දෙපැත්තෙන්ම අහු වෙනව නේද? Bimanually. So I told you, I've shown you the technique how to look for bimanual palpable masses, right? Like that. So it is bimanually palpable and palatable. Bimanually palpable and palatable. So the location is in the loin region. It is moves minimally with breathing, bimanually palpable and palatable. These are all physical signs of a kidney. And what happens if you percuss this mass? On percussion, because the kidney is a retroperitoneal structure, you will have bubble lying on top of it. So there will be regions of dull resonance. These are called bands of resonance. So when you percuss the kidney, you will find that there will be bands of resonance on the surface. Areas or bands of resonance on the surface. So those are the physical signs of a renal mass. Liver again, like our Pansil Padapa, 10 commandments and all of these things, like that you have to know this. So liver, right hypochondrial, moves downward with breathing. You cannot get above the mass, and the dullness is continuous with the liver dullness. Spleen is in the left hypochondrium, moves diagonally with respiration, moves or enlarges towards the right iliac fossa. You might feel a notch in the anterior border, and percussion is continuous with the splenic dullness. Kidney, enlargement is in the loin region, bimanually palpable, palatable, and there might be bands of resonance on top of this mass. Those are the physical signs of a renal mass. So I told the first step was therefore to identify organomegaly. and we have done that. Right? At the exam, sometimes you get a ascites case where there are no organs to palpate, so don't worry too much about that. Right? But commonly you get these organs, organomegaly patients. Hari. So once you identify the organ, the next step is to generate a differential diagnosis. Now I'm going to show you some tables where you have to memorize. And when you basically go through your second appointment and then come to your professorial appointment, this should be just flowing out of you. Okay? Flowing out of you when you come. So these are all the causes of isolated hepatomegaly, splenomegaly, and hepatosplenomegaly. And I have used certain themes or categories to help it make it easier for you to remember this. Kala varahang athule tiyena certain critical characteristics of these causes. So if you take hepatomegaly, viral hepatitis is an important cause of isolated hepatomegaly. And there the liver is tender and you get icterus. Okay? Alcoholic hepatitis can cause isolated hepatomegaly. And as you remember, alcoholic liver disease features a patient තියෙන්න පුළුවන්. Hepatoma or hepatocellular carcinoma can cause hepatomegaly. But there you know that the liver will be sometimes massively enlarged, hard and irregular. And you might get a liver bruit. Okay? Autoimmune hepatitis, those sort of things are rare. Amyloidosis is rare. The only thing you need to know is amyloidosis can cause a massive hepatomegaly. Right? Then the other common ones are congestive heart failure causing a right heart failure causing a hepatic enlargement. Okay? And the liver might be pulsatile, especially if they have a tricuspid regurgitation on top of that. And liver can be enlarged in the early stages of cirrhosis as well. Okay? Remember, in cirrhosis, the liver is, you know that it's shrunken, but write this down, the liver can be enlarged in the early stages of cirrhosis, number one. Okay? Enlarged in the early stages of cirrhosis. It can be enlarged because there is a malignant process in the liver. So these are two of the cause of enlarged liver even in the setting of cirrhosis, right? Early stage of cirrhosis and also malignancy within the liver. So these are some of the cause of isolated hepatomegaly. Viral hepatitis or exam meke hari, case ekaka hari, what to hari, you will see a right, you find a liver. What is your differential diagnosis? The first question is, why do you say it's a liver? Now you say, right hypochondrial mass cannot get above it, moves down with respiration, percussion is continuous to the liver dullness. Hari, then what are the causes? Then you have to think, right, could this be viral hepatitis, alcoholic hepatitis? Could this be a hepatoma? Could this be right heart failure? Could this be cirrhosis? Then you use the other characteristics to try to narrow down your differential diagnosis, right? If it's tender, it's probably infection, no alcoholic hepatitis. If it's hard and there is a bruit and all, it could be a malignancy. You narrow it down. Then splenomegaly can be due to infections like endocarditis and IMA. You get a very small, tender spleen, soft, small spleen in infective causes of splenomegaly. We'll get this slide so you can remember it. Right? Splenic lymphoma can also cause splenomegaly, and right down there it can cause a massive spleen. Right. Now, I have not put here under infection, visceral leishmaniasis and chronic malaria, which can also cause massive spleens. So please write that down. Okay, infections, chronic malaria, that's also called tropical splenomegaly syndrome, TSS, and visceral leishmaniasis can also cause massive splenomegaly. Neoplasm gattut, splenic malignancy like lymphoma can also cause massive splenomegaly. Right. Then you know hematological cause, hemolytic anemia, myeloproliferative diseases ගැන ඔයගොල්ලෝ ඉගෙන ගන්න තියෙනවා hematology module, polycythemia rubra vera, myelofibrosis අනමන ඕවා ගැන. And also lymphoproliferative disorders like lymphomas. They can cause splenomegaly, as you can see in this table, or hepatosplenomegaly. right? දෙකම එන්න පුළුවන්. Mostly ඒවායින් එන්නේ ඇත්තටම splenomegaly. හැබැයි hepatosplenomegaly දෙකම එන්න පුළුවන් because in all these hematological conditions the spleen and liver are overactive and producing blood cells. Also highlighted in this, myelofibrosis can also cause a massive spleen. So now I have given you 4 causes of a massive spleen which you need to remember. මේවා ඉතින් අර ජාතික ප්‍රශ්න හරිද? Right? Visceral leishmaniasis, tropical splenomegaly syndrome in malaria, myelofibrosis, splenic lymphoma are 4 of the important causes of massive spleen. You can have third spleen crossing the midline, massive spleen, usually crossing the midline. Autoimmune disease can also cause splenomegaly rarely. Felty syndrome is a especially important one where you get splenomegaly in rheumatoid arthritis and leukopenia. Okay, white cells are low and the spleen is enlarged in rheumatoid arthritis. Rarely seen now because you have biologics now and disease modifying drugs. And rarely portal vein thrombosis can cause splenomegaly. Right? Hepatosplenomegaly, again hemolytic anemia, myeloproliferative disorders, lymphoproliferative disorders වගේ වලින් තමයි එන්නේ, and also cirrhosis with portal hypertension can cause splenomegaly. Right. So these are some of the causes of hepatomegaly, splenomegaly and hepatosplenomegaly. ඉතින් මේක කටපාඩමින් දැනගන්න වෙන විදියක් නෑ මේක කරන්න. You are definitely going to get asked these 2 questions. What is the organ and why do you say it's the liver, spleen or kidney? And then what is the differential diagnosis? So you need to learn these lists. What can cause enlarged liver? What can cause an enlarged spleen? What can cause both liver and spleen enlargement? Right? And these are some of the other tables for your reference which help you a little bit more in analysis. Spleen, again, I have given you meta-analysis using some findings in the general examination. And I have given you the cause of mild, moderate and massive splenomegaly. Another disease that we did not discuss in the previous table is CML. That can also, it's actually a myeloproliferative disease which can also cause massive spleen. So massive spleen due to myelofibrosis, CML, visceral leishmaniasis, tropical splenomegaly syndrome, and splenic lymphoma. So those things you need to remember. Right? So these are all for your reference. So remember this table. I think this table is reasonable, but there are some things missing in this table. ඒක ඕනකමින් කරපු එකක් because නැත්තම් මේක උඹලා ඕකරම් ඕකම කටපාඩම් කරගන්න. You need to do some of your own digging and you fill some of the blanks in this table like I have discussed now. And also remember causes of splenomegaly. You remember the cause of massive splenomegaly, which is important. Palatable masses are, if it's bilateral, it is probably due to polycystic kidney disease. If it's unilateral, it may be hydronephrosis or renal cell carcinoma. That's it. So it's a short session because abdomen is easy. So abdomen interpretation of physical signs, identify what organ you are dealing with, whether it's liver, spleen or kidney, and then based on that, you generate a differential diagnosis. Isolated hepatomegaly, number 1 question, why is it the liver? You know the answers to that. What could be causing it? Differential diagnosis, you say viral hepatitis, alcoholic hepatitis, hepatoma, and congestive cardiac failure, cirrhosis. So and then using the general examination, you can narrow things down, like I have shown in this table, and also within brackets in this first table. If it's a spleen, why do you say it's a spleen? You say it's a spleen because it's the left hypochondrium, moves diagonally with respiration, enlarges towards the right iliac fossa, and there is a notch in the anterior border of the spleen, and you cannot get above it. And the percussion is continuous in the splenic dullness. Splenomegaly, based on size, the causes can be different. Massive splenomegaly can be due to CML, myelofibrosis, visceral leishmaniasis, tropical splenomegaly syndrome, or splenic lymphoma. Other causes of splenomegaly, soft, small spleen in infections like IMN and endocarditis, right? And also you can get splenomegaly in hemolytic anemias and Felty syndrome and portal hypertension. Hepatosplenomegaly can be again due to hemolytic anemia, myeloproliferative disease, lymphoproliferative disease, and cirrhosis with portal hypertension. And your general examination is going to help you to narrow these down. Okay, for example, hepatosplenomegaly due to a lymphoma, you will find lymphadenopathy. And this table is going to help you to identify that. Usually I ask you to do this for homework, but I know you buggers will never do this. So I have given you the tables to study, but I have put certain gaps in this so that you can fill it up on your own. Alright? This table, all these 3 tables you need to remember for your abdominal examination short case. And obviously for day-to-day ward work. Hari. So that is it for the abdomen. Do you have any questions? So I've gone through with you the examination technique and also how to analyze, interpret physical signs. First, identify what mass you're dealing with. Number 2, you identify what differential diagnosis you are dealing with. If you get ascites only, the cause is almost always cirrhosis and portal hypertension, right? But rarely, it could also be, what are the other causes of ascites? Which are not due to liver disease. There are other causes of ascites. Write this down. It's not on the slides. So if it's ascites, it could most often it is due to cirrhosis portal hypertension, which you have seen in your lectures. People have taught about these things in your lectures. All right. Other causes of ascites could be, number 1, for example, ovarian cancer in females, intra-abdominal cancers in males like pancreatic cancer, TB peritonitis can cause ascites. TB peritonitis. Okay, TB peritonitis can cause ascites. And very, very rarely, a disease called constrictive pericarditis can also cause ascites. Constrictive pericarditis. Read a little bit about constrictive pericarditis for homework today. Okay, so ascites can be due to liver disease, most likely. So 80% of the time it is due to liver disease. But it could also be due to infections like TB peritonitis, intra-abdominal malignancies like ovarian cancer, pancreatic cancer, okay, and also those are the causes. Right, any questions? Right, okay, so today's a relatively straightforward class. I'm not surprised that you don't have any questions. It's very, very straightforward. Okay, Sachit. Right, so Sachit, that's a good question. So he's asking, in aortic stenosis, why don't you get cardiomegaly? So aortic stenosis, you can get cardiomegaly in the very advanced stages. But remember that the first thing that you get is because of the pressure overload, because aortic valve is narrow, because of the pressure overload, the left ventricle hypertrophies, and this is a concentric hypertrophy. Concentric yani mehema loku wena mehema size එක නෙවෙයි. Basically the layers build up, narrowing the cavity of the ventricle. So it is a concentric hypertrophy that occurs. So you don't get cardiomegaly because of that. But obviously with very, very advanced aortic stenosis, the heart starts to dilate and fail. And you can get cardiomegaly in the very advanced stages of aortic stenosis. But it is mainly the predominant pathology is concentric hypertrophy. Hari. Right. So now the only thing left to do is neurology. We have done history taking, we have done cardiovascular, respiratory, abdomen. And now we will have 2 classes on neurology. Are there? Now I realize that samula batch ekේ භාගයක් ගෙවුම් විතර නිදි, I don't know what the hell they are doing. Because only 120 or so join this class. I don't know what the rest of the buggers are doing. But whatever they are doing, make sure that they attend a neurology class. Anithyaට ආවෙ නැතුවට කමක් නැහැ. Make sure that people try. I know that some people might have data problems and that is not a problem. But people who can attend, please make sure that you come on Monday and Tuesday and attend those 2 classes, because those are extremely important. And I cannot emphasize enough how, from my experience, I know neurology is the most difficult for medical students, postgraduates. And this is obvious. Yesterday I did a Zoom class for people who are doing MD in ophthalmology because they don't remember their neurology. Neurology case as well as neurology. but again they find it difficult. So even at that level, even at a postgraduate level, people find neurology difficult. So you have to get your basics right. And I'm going to do cranial nerves on Monday and the limb examination on Tuesday. This is very, very important. I can't emphasize how much important this is. And basically, this is gathered from a lot of places. Nobody else is going to teach you this type of interpretation in neurology. So make sure that you come on Monday and Tuesday. All right? Very, very important. Tell all the buggers to come. All right. Saragan, is that okay then?
Yes, sir.
Okay, right.
Yes.
So, Podakinda, lobar collapse. Take a homework, homework. So we'll discuss that on Monday. What are the? I asked you to look for signs of lobar collapse versus whole lung collapse. What are the different? It is different. So to answer part of your question, it does differ from a total lung collapse. The physical signs are different. So again, I want you to find out. Put it on your group, then everybody can read, and you find that out. Okay. Right. Okay. Then I'll see you on Monday. Then make sure that people who are not there, please pass the message for you to come because that's very, very important.
Okay, sir. Thank you.
Okay, sir.